Thanks everyone for attending. I hope this is useful to everyone first and foremost, and it's worth the time in the evening that you're going to put to it. I'm going to try and make it worthwhile for you. What I'm hoping to do this evening is, first of all, just offer some insight into the GI HPB specialty. I'm going to do that by sharing my experience and my journey, because that's all I know. Okay. You know, everyone has slightly different paths. Everyone has different influences, and there's different roadblocks along the way that you navigate. So I can only go from my journey and really show you, sort of talk to you about what happened to me, because I've ended up in a funny position, and I never really thought at the start this is where I would be. But I really have to say that I enjoy my job. I love it, most bits of it, apart from the on calls. But then I think that's just the balance of what we've got to do with that. Okay. I'm not going to take too long, hopefully. I'm going to try and help you think a little bit broader about what you want to do. I'm not selling the career in GI or HPB. I'm just telling you why I like it and what influenced me to do it. And I think, personality traits that you have to be honest with yourself about will sort of help you decide that specialty in any instance anyway. So let's get to it. So as I've got older, I consider myself mid-career. I'm 45. And I've finished, as James said, I completed my training in 2012. And as you get older, you sort of get a bit more philosophical. I'm definitely in a philosophical sort of era. This quote is sort of just a little homage. I'm not a fan of Oprah. Okay. And therefore, you're putting the hours in. It's not a 9 to 5, Monday to Friday. It's not even less than that. It's way more than that, and you know it. So you can't really do it and not enjoy it. If you're doing that, you're going to spend 40 years miserable, and you're going to look back on it and think, what did I do? Okay. So you've really got to go for this and decide, actually, what can I see myself being happy doing, rather than what does the market need? What affords me the hours that I want, that sort of stuff. You've really got to enjoy the content of what you do. So go after that is my first bit of advice. Okay. I definitely did that, but I did that after considering everything else. Initially I wanted to be a millionaire or whatever, and I just wanted to have good life, lifestyle on my own. And I just thought, every time I considered something else, I ended up coming back to GI, and there's reasons for that. My plan, well, in ST1, I didn't have one. I did a basic surgical training before radiology, and just during that 2 years, I hated it. I loved the operating, the theatre environment. I didn't enjoy it. I was honest with myself at the end. I didn't enjoy the ward work, and I didn't really particularly enjoy clinics. So I was kind of just getting into radiology. I was just relieved to be leaving surgery, but I didn't really know that radiology was going to be what it was going to be. I think most first years spend a bit of time going, what have I done? I'm in some environment that I don't really understand. I feel like a med student again. I don't really know what I'm doing. Okay. And then you start revising for that FRCR part 1, and you just think, oh my God, I can't even remember any physics. But I went into radiology because I didn't really like surgery when I tried that, but I knew I really liked anatomy. That was my thing at med school. So it made sense to me, but it was a leap of faith. Okay. So ST1, I just sort of settled in. ST2, you got your part 1 done, part 2A prep. Believe it or not, the only module, this was back when you did 6 modules and you could choose how many you did at any given time. You didn't have to do them all at once. The only module I failed first time was GI. So it really did make me think, I've come from a surgical background. I thought I was going to be a GI radiologist. I must be rubbish at it. Is this the right specialty for me? Should I be doing something else? But during that year, you do become comfortable with your on-calls. You settle in a little bit more. You feel a bit more at home in radiology, or at least I did. And, during that year, I also got the opportunity to get a bit more hands-on with ultrasound-guided drains and biopsies and things like that. So, there was confidence coming from that, even though I failed my GI module. So that left me in a position where I was sort of thinking, well, okay, is GI for me, or should I be doing something else? I was really confused by all the specialties, because you get into radiology and you realize, actually, there's so much to do: neuro, Uro that Rachel's going to talk about afterwards, interventional, chest, all sorts. And it's, you get in, you spend that first year settling in, and it's before long you need to make these decisions or start thinking, well, I think that's what I want to do. And it's really hard because of the range. In ST3, I sort of chose abdominal and non-vascular intervention because, like I say, I kept looking at other things, but I kept coming back to it and going, well, that's where I'm comfortable. So it was another leap of faith to kind of say, well, yep, I'll do that. And I say leap of faith because I wasn't confident that that's what I was going to end up doing. That's what I really wanted to do. I just thought, well, that's what I feel like I'm good at. And some people had said that to me as well. Brings me to my next quote. There are going to be a few. I apologize if you're not into quotes, but you can't make progress in a career without making decisions. If you don't make decisions, you're going to drift. So there are going to be natural points, and these points where you're going to have to make a decision and go on, even if you're not ready to. And that was me in ST3. I didn't know that I wanted to do GI. I didn't know that I wanted to do HPB, but I sort of liked it. And as much as I liked other things, for example, breast imaging, I did it. In Manchester, we used to do 6-week blocks of specialty in year 2 to sort of give us a taste before we made our decisions. And I remember doing a breast block, and I just thought the whole environment was brilliant, where you got to work directly with clinical teams. You did a bit of hands-on procedures, biopsies, and you did some radiology as well, with some conventional radiology. So it was all in the same environment. And I thought that's exactly how things should work, and I really liked it. But I came back to GI, and that's because I had to make a decision at the point I had to make it, and I wasn't 100% sold on any of the other specialties, if I'm honest. So senior training, ST4 to 5, passed the 2B, passed early in ST4, and I think this is key. If you do one thing, especially in the ST1 to 3s looking forward at the moment, is pass your exams quick, because that affords you opportunity to think and opportunity to try things at work. And in the final 18 months after the 2B, I really enjoyed working. I just, radiology was my thing now. I felt good at it because the 2B gave me that confidence, and I just started, really pushing myself and doing things in GI HPB that I just thought, well, I should. This is where I'm going to go. This is where I'm settling. So I did an abdominals fellowship as well, and that was in Toronto. And I'll tell you, the reason I did that was not because I wanted to be, I did want to improve. But I think in my training scheme, I wasn't anything special. I wasn't the guy that everyone thought of when they thought who's the best in abdominal imaging. It wasn't me. I was pretty average. I jumped the hurdles. I passed the exams. I did the work. But I don't think I was particularly brilliant. So I don't think I was ready to be a consultant when I CCT'd. And I didn't think I was going to be. So that's why I did my fellowship, because I just thought, actually, I need to get some volume. I need to try something to try and finish me off and make me another level. And it really did that. If you look at those numbers of imaging that I reported in 1 year, that's significant, and I finished up feeling really confident that actually, I can do this. I know what I'm doing. I'm good. So why did I choose it? Well, I've tried to list some of these. So I had a surgical background. Yep. That helps. It gives you context and it preps you, and you've already got that sort of surgical thinking in GI, which I think you need in HPB, because you need to. A lot of it is knowing what the surgeon needs to know. I had senior examples that I looked up to, consultants that I worked with, that I just thought, actually, I looked around and I just thought, I want to be like them. I'd be happy doing a job like theirs. And I think that also bears an influence on you. I had some feedback saying, yeah, you're good at GI, you're good at non-vascular intervention. So that obviously plays on your mind as well. And I really liked in GI the variety of MDTs that you get. So there is a massive range in abdominal where I didn't think that existed in most other specialties. And I'll come back to that a little bit. The mix of practical procedures was really great. Market forces, yes, I did think of that. In all honesty, abdominal imaging is always going to be around. GI, HPB is, in combination, probably one of the more complex and rangy specialties, which means that actually it's going to be the last thing that technology takes away from us. It's going to be, the thing that you always need a human overseeing. So I just thought, actually, it's part of every radiology department. It's not it's general as well as subspecialty, and therefore it'll always exist, and there'll always be a need for people that are good at it. It does have some easy cases. It does have some challenging cases within it. The MRCP is sort of my break from really complex, transplant imaging that we sometimes have to do, or PSC imaging that we do in the specialist centre I work in. A nice MRCP with a stone in it is that 5-minute break where you go, oh, that's nice. I'll relax and report this one. So there's this huge range of complexity as well, and every modality we have is used in GI and HPB as well. So I just liked the fact that it was great. What you can see in the top left there is a contrast ultrasound, and that's showing an arterially enhancing HCC. Lots of new techniques. That contrast isn't new anymore, but even if you're not into intervention, that's a fun thing to do. And the abdominal applications in it are really good. Similarly with elastography, loads of different MR techniques for abdominal as well. So I just thought, actually, there's so much to do here. I'm always going to be interested. But like I say, I was never 100% that this is where this is where I belong. I just thought, actually, I can be good at it, and I think there's loads to do, and let's go for it. So it was a leap of faith at the time, because you hit those milestones and you have to make those decisions. Another quote: "May your choices reflect your hopes, not your fears." Okay. I think using a positive attitude to choosing your specialty is so important. If you think, I'll do this specialty because I don't really like that one, that's you'll end up in a position, I think, where you don't enjoy your work. You just sort of fall into it and kind of think, well, here I am. So I think you've really got to be honest with yourself about what you like, okay, and what suits you and what your personality works with. The clinicians around your specialty, are they the type of people you get along with? And they the type of people you're on the same wavelength as? Because all of that makes a difference. As a trainee, you're sort of a little bit distant to the clinical teams, but as a consultant, you have to integrate with them because you're part of their service as much as they need you. You need to be integrated into theirs as well. So you have to build those relationships as well. And therefore, if you don't like the fact that neurosurgeons tend to be a bit more dominant over knowing their imaging and deciding for you what they want, and there's no discussion about that. For example, and I know I'm being cliche there, if you don't like that, then and you like to be part of that decision making and part of the clinical side as well, then you need to choose a specialty where it lends itself to that. So I'm just this isn't me blowing my own trumpet, but I'm just showing you here the roles that I have in the DGH versus the tertiary centre. So the DGH roles are on the left and the tertiary centre are on the right. And you can see on the left, I do, when I was full-time in the DGH, I'm now part-time in both, but when I was full-time there, I did a load of stuff. And this just highlights the range of specialties we've got: colorectal, upper GI, bariatrics, IBD, HPB, and Euro. And within that, in the 6 years I worked in the DGH, solely in the DGH, I set up various services, including the fusion prostate biopsy service. I was central to setting up the IBD MDT, which didn't exist before I was there. So there's so much to do, and you'll find that in most hospitals that certain bits don't even exist where you've worked compared to places you've worked before. So there's opportunity. On the right, obviously, when you go to a tertiary centre, it's built and it's ready, and there's loads going on, and you sort of slot in, to the services that exist. There's loads of complex stuff there. And what a tertiary centre gives you is exposure in your specialty. I'm the same guy that I was when I worked at Worcester, but suddenly when I was in Queen Elizabeth in Birmingham, I was asked to present a lot more nationally. I was asked to apply for the education officer role in Biscar. My private practice sort of picked up a little bit, and in the bottom role there, it's an in-house clinician role for a medical device and notary body. So it's a regulatory company that approached me and said, we need someone with your experience, with your knowledge, that can assess devices against regulation to make sure that the claims they make, that the manufacturers make, that they can do clinically are reasonable. Now, I could have done that from Worcester, as the same guy with the same knowledge, but the exposure that maybe the tertiary hospital gave me meant that they approached me there. And it's a really interesting role, that, because I get to see devices before they come to market, and I get to look at them and sort of figure out what's coming, so I can see a little bit ahead. And that opportunity comes from being probably in a tertiary hospital a bit more than a DGH, but it's because of working in our specialty that we get that, and because of the range that we have, that those sort of opportunities come, I think. So I've talked a little bit about that. Obviously you've got to decide as well what type of person you are, in terms of, are you a subspecialty person or a super specialty person? Do you want to work in this area of your specialty, or do you want to do a bit of everything? Okay. I know in Uro, Rachel knows him well. Tristan Barrett was my year of the fellowship in Toronto, and he very much spends a lot of it, the vast majority of his time on the prostate. Now, he loves it. I couldn't, but he loves that. And as much as I love HPB imaging, I don't think I could do all day every day just doing HPB. So you've got to decide that as well. But the security is great in GI. It's needed everywhere. All of those options are on the table. And I think as time goes on, lines are becoming more blurry. I do EUS and the ERCP. Those traditionally were done by gastroenterologists, hepatologists, and surgeons. But increasingly, radiologists are getting the opportunity to do that stuff. It's a funny situation about how that happened to me. After the fellowship, I was pretty confident. I settled in really well to Worcester, and I was asked to do that by one of the surgeons, because he wanted me to do it as a radiologist, because he said, I can do radial ultrasound, but I can't do the HPV stuff because I'm never going to know what I'm looking at. You do. So it took a bit of convincing, but I trained up to do that, and now I'm on sort of, I'm doing it in one of the biggest tertiary centres in the UK, one of the highest volume centres, and talking about it as well at the US conferences. So it's, I think those lines are becoming blurred, and I think being a radiologist doesn't necessarily mean just doing imaging. What's happening in GI HPB? I think it's a growing community. I think that people are organising themselves. BSCAR is a great significant interest group, and the membership I can see is going up year on year, and we're getting representation from loads of different geographical areas of the country. I think this is really important, because I think where you've got good organisation in the workforce, you get development as well. And the HCC standards that are just coming out, I'm not saying you need to go read that in any detail, but where the workforce organises, so does the services. And when services organise, you achieve excellence. So nationally, our standards are really improving in GI. We're already respected across the world for our GI radiology. I think that's only going to get better in time. And with that as well, you will have the opportunity to contribute to these sort of services and these sort of documents. HCC surveillance, we've been doing it for decades, but we've never done it in an organised way. And this is now coming very recently. November 2024 was the last update, and it's a really nice document to say how we should be doing it. Now, everyone fears AI, of course, we do. But is it taking over? Well, I don't think so, not in GI. When you look around the marketplace in GI, yes, there are niche products. There's a couple here that I've just shown up, and these are just examples. There's loads, but there's an MRCP product that will identify which duct is which, and it will tell you if there's any biliary variation, to say, well, this is what you need to look out for if you're going to do a cholecystectomy, for example, if there's biliary variation. But that's so niche, it's not gonna, you're not going to be able to plug that into PACS and say, right, your abdomen's going to get reported, because there's so much other pathology in there that actually it's going to miss, obviously. Similarly, it can be used, it's going to be used more, I think, for planning. So, in resections of big HCCs, which is what this is, we tend to do in in our unit a volumetry assessment, which is really, really quite time consuming, because you've got to draw around every bit of the liver as to which is going to be the remnant, which bit's going to be the remnant, and which bit's going to be, removed surgically. And then you get this volume which says, okay, you've got this much percentage, and therefore it's safe to go ahead, because they're not going to go, the patient's not going to go into liver insufficiency afterwards. It takes time to do that. That's the stuff that we want AI to take. Okay, and I think that product is coming, and it does exist, and it's going to give us time to do other stuff. So I think in abdominal, I don't see AI as a threat. I see it as a help. I'm not worried in the slightest over the next 20 years that we're going to lose work and be twiddling our thumbs, jobless with nothing to do. It's such a rangy specialty that I think we're fine. But actually, these AI products will be really, really funky and really useful. Again, like I say, these products are likely to join the market with specific and niche functionality. I've been involved in a review on AI, so I've looked into this, recently, and obviously with that notary role, I do see a lot of software coming through as well now as medical devices, and I don't see anything in any form that can scan an abdomen and tell you what's wrong. That's not what's going to happen. So to finish up, and I hope I haven't run over, but my advice to you is choose positively. Decide what you want to enjoy. Don't decide, I don't like that, therefore I'm going to do this. Really think down, what am I enjoying about my specialty, about radiology? Which bits do I like? Which bits do I not like? When you've decided, and consider your life as well. If you're someone that really, really, your well-being depends on a good balance, then that feeds into your specialty choice as well. It has to. But once you've decided, then aim high. Nothing's out of reach. Even if you think you're average, like I did, you can get to wherever you want to be, tertiary, world class if you want. It's all about effort in our specialty, and I think options are and opportunities will come to you if you work hard. And also remain, like I say, that leads on to point 3. Be open. I didn't really decide to do a US. It came to me because a surgical colleague asked me to do it. I thought about it and I thought, okay, yeah, fine. But now I love it. It's the main part of my job in both sides, and I really enjoy it. So my final quote: success is getting what you want, but happiness is wanting what you get. I really think that's true. But you've got to be really active. 5 years is a short time to get through radiology training. I think in honesty, it should be longer, although I didn't want it to be longer at the time. Because you have to make your decisions so quick, and it's almost unfair to have to do that. But it is what it is, and you're walking the same path that I did. So good luck to you all. And I think we're doing questions later, so I will stop there.
So what was my pathway like? So I did anatomy demonstrator as an F2. I quite enjoyed realizing that I basically graduated med school when Sharan had CCT, so I feel nice and youthful. I loved being anatomy dem. It was my favorite job in the world. And I obviously, being the very highly functioning individual that does loads of stuff rather than sitting still, did my postgraduate certificate in medication as an F2. I then did core surgical training in urology, and I did that theme in Cambridge. And that was my first exposure to radiologist. Until then, I'd never even thought of it as a career. But I met a really great kind of group of radiology trainees that had often switched from surgery and got exposed to actually what would be my future career. And here's a shout out to everyone's favourite, or probably I should say second favourite after Sharam's, Beskar radiologist Ed Godfrey. I spoke to him on the phone. I thought he was a reg. I asked him if he could sign up a purse I could book the patient for theatre, and he offered me and signed me off for a taste a week. And if that hadn't happened, I would not be here now. So, Prostates of Yorkshire, thank you, Ed Godfrey. I did my core radiology at London in Chelsea and Westminster, and then did my sub-spec at UCH for ST4 and 5, and that featured very heavily COVID. It was essentially a COVID sub-spec block, and Viva La Sheffield is where I am now. Your path will be different, but all paths are good and valuable, and it's about making the most of the path that you get and learning from the people that you're exposed to be the best doctor and the best person that you can be. So what do we think about Eurorad? I essentially think uroradiology is split into three components of what makes it great. One of them is diagnostic. So there's reporting, there's MDTs, there's trouble solving with the urologists. Essentially, you're the Sherlock Holmes of the water pipes. There's intervention. Again, this can be huge and varied based on where you're working. If you are doing super specialized, is your IR split vascular, non-vascular? Are you in a DG8 bits, etc.? So there's lots of different components for the vascular or the interventional component. And then research is something that I'm really passionate about and which Sheffield does a lot. So I'm really fortunate to be able to do quite a lot of it in my job. So I'm very simple. I also love anatomy, urogenital radiology. Simply this: 2 kidneys, 2 ureters, a bladder, in about 50% of the population, a prostate, and then a testes and penis. That's an anatomical cross-section of a penis cake that I made as an anatomy demonstrator when it was one of the medical students' birthdays. And thankfully, the dean of the anatomy said it was anatomically accurate, slightly better than the other kind of ones you can get. This is essentially the body parts that you'll be dealing with on a day-to-day basis on a urogenital radiology. I love these body organs. They're very important. For diagnostic, MDT will be a huge part of your job. And again, this really depends on where you're working. So for me in Sheffield, I do a lot of volume of MDTs and a lot of different ones that are to different places. So MDTs, some say, are the bane of people's lives, but actually it's where you make a huge difference. You are pinning together all the information, you're talking to the urologist, the oncologist, and you're making a huge difference to surgical outcomes or treatment plans for patients. So it is hugely valuable, even if it is a 7 a.m. start for me tomorrow morning. So I do a regional Uro-Onc MDT every Wednesday. And again, this depends on where you're at. Some places split the cancer MDT based on which kidney or prostate or bladder it is. Ours, we do all of them. So essentially, we do all of Sheffield patients. We do prostates, then we move on to renal, then we do bladder, then we do testicular, then we do oncology trial patients, and then we go to our feeder centres. So we have 4 DG8 places. We have Chesterfield, Rotherham, Barnsley, and Doncaster. And we review all of their cases in our regional MDT. So it's pretty heavy, but you get to make a huge difference to them and the treatment options they have. So it is very satisfying, although MDTs can be quite a lot of prep work. We do reconstructive urologies, and I really enjoy this. If you haven't heard of the term, this is essentially benign plumbing, but benign complex plumbing, to the point of the MDT will give me a headache prepping it because it's so confusing trying to work out what's plumbed into where. Is the ureter into a conduit? Is it a neobladder? Is it into the sigmoid? What's the function of the kidneys like? What are their symptoms like? We have a lot of ketamine use, and that's stenosing all the bladders and the ureters. But it is a really satisfying one because you've really got to put your detective hat on. I truly feel like Sherlock Holmes in a reconstructive MDT, putting together the symptoms of the patients, the pre-op imaging, what plan they want to do, what's the operation. And it's a real team effort, and the urologists really know their patients. They're really invested. So I really find that one a satisfying MDT because I can see how I'm making a difference to some really kind of debilitating symptoms to some of the patients. We do endourology MDT, which is short, really, isn't it? Is there a stone in the kidney? Is there a stone in the ureter? Do we need to operate? And that's essentially that. But generally, endourologists are really fun to hang out with. And also ones that I've learned about in Sheffield, which is our renal AML or polycystic kidney disease. That's a big MDT where essentially I spend a lot of time counting lots of different cysts. And actually that's because Sheffield is a big regional centre for medical treatment for AMLs. And actually, so they need to do all these different MR and reset sequences to see if the AMLs are shrinking, do they need embolization, or has it accelerated a growth of a different tumour? So that's a new and emerging one that Sheffield is actually leading the way for. So that's quite an exciting one to be part of too. And they've done lots of work with AI as well, correlating a link between the size of the kidneys augmented on the MR sequences and timing that with when or not they need to have a transplant, and they've spotted a link. But your MDT exposure will be very different based on where you're at and what centre and what centres feed in. So basically, I would just get as much experience and work out which ones you like and which ones you can then kind of get to grip with. So I'm also a big fan of getting food at your MDT, which we've managed to get as some of them. They're essential. Fluoroscopy as well. Fluoroscopy is what I spend my Tuesday mornings doing. It's not the most glamorous because essentially it's urine in contrast. but it's really satisfying, and you get to go alongside the patients and really make a key difference. So here you can see, right, not many times you have strain written on a live x-ray. What's happening? Well, obviously the patient's had a big pelvic fracture. We can see that because they've got a dynamic hip screw in the femur and their pelvis just isn't joined up. So they're straining, but nothing's coming down through the prostatic urethra. But we can see an ascending showing there is something in the urethra, but it's not joining. So this patient had had a huge traumatic road traffic accident and essentially transacted their penis. And so that bit's completely disjointed. So actually doing all the imaging properly means that the urologist is trying to work out how can they rejoin different parts of the urethra to enable this patient to void again. So it's really, really satisfying, and a really kind of like, you really have to get your head around all the different imaging that you're doing. Sensory fluoroscopy is a lot of stricture assessment for pre and post-op, and lots of pre or post-op leaks, but also assessment of fistulas, either vesicovaginal, bladder to bowel, bladder out into the skin. And actually, a lot of them, especially if they're younger men's, can be a really kind of stressful environment. So actually, it's a really great time to get alongside them, reassure them, go through the imaging afterwards. So you get to make a big difference. And as I say, is it glamorous? No. But if anyone's ever had any issues with their waterworks, it can be hugely debilitating, having to plan your day around which toilet to go to. Can you or can you not do this long car trip? You're actually part of that journey of enabling to get back to having a normal life. And they love that. And it's like, actually, I love the fact that I can make a difference in that way. What about intervention? So disclaimer, I'm not an interventionist. I wanted to learn NEFs and do more procedures, but COVID put a banner in that, or a spanner in that, should I say. So I can't do intervention. I don't know the words like spanners or big procedure things. I focus my time on diagnostics and research and education. You can't do everything well. But the rest of the team, so 75% of my team, so the rest of the men, they all do intervention. I'm the only one that don't. And it's obviously reminded to me quite a lot. So what sort of interventional things can you do? Again, it depends on where you work, but a key part of that is nephrostomy, so essentially draining the kidney, and that could be due to a septic obstructive stone. It could be due to nodal recurrence or tumor spread that's blocking the kidneys. You can do transperineal biopsy, so you're targeting lesions in a safe way with less sepsis and TRUSP. And these are lesions of the anterior lesions in the prostate that typically we would have missed previously before MR. We're doing really, really cool stuff with kidneys. So you're doing minimally invasive things such as tumor ablation, cryotherapy. So these are people that might not have been operative candidates or might not be able to have a big operation. You're able to preserve the nephrons of the rest of the kidneys and use emerging non-vascular kind of techniques to ablate the tumor, and it's making a huge difference in the prognosis and outcome of small renal masses. And that's an emerging role that you could have a part to play in. Suprapubic catheters as an emergency or as a routine. PCNL, so hanging out with the urologist in theatre, putting the nephrostomy in, dilating it up and lasering the stone. The main thing is you get to hang out with the urologist in theatre. That's what the most fun thing is. And nephrostomy is an antegrade stent. So there's huge variety. It's really flexible. There's a lot of things that you can do, and it's really interesting. And you can do less exciting but equally vital brains or biopsies. Ultrasound. So I have a dedicated Uro list. For our specialist list, essentially you're going, am I scanning the kidneys? There's 2. Bladder, is it full? Testes, what's going on? And penis. So my list is just testes and penis, and I absolutely love it. It's really good for trainees as well, because often they can be scared about doing testicular ultrasounds, scared about doing them on call. And actually, I'm able to show them the 100% valid Rachel Hubbard way of scanning a testes, a nice, thorough, methodical way, which means that you don't miss things. I have slightly longer with my patients because often they need a bit more encouragement or to chat things through, especially for the penile ultrasound list. But it's really great to go from them being scared and nervous to showing them what the pictures are. And they can often leave with a smile because you're able to tell them straight away, A, your penis is normal, or B, you don't have a testicular tumor. And I really like that kind of relationship, kind of nurturing aspect that you get to do in what is otherwise a stressful environment for them. Gynae radiology. So this is my one token slide about the ovaries. I didn't actually do any gynae radiology, but I've been firmly told by all my gynae friends I need to mention it, otherwise I'll get told off. So we will not forget them. Do I do any gynae? No. Do I ever want to? No. But they're a valid part of our team. And you can do great things such as HSG, fertility workup, transvaginal ultrasounds and biopsies. There's a lot of emerging role with pelvic floor and mesh. So it's a huge emerging field. And again, your experience of gynae will be dependent on where you are. In Sheffield, we have about 70 radiologists. It's huge subspecialty split. So there, I just do Euro, my office buddy just does gynae. Other places, you might do Euro and gynae. You might do gynae and GI. So kind of use your experience, and there's always someone around to be able to help. And you can even do things like placental, MRI, fetal MR as well. So there's a lot of kind of antenatal aspect to that as well. Consider gynae. That is my one token slide. And research. This is something I'm really, really passionate about, and I absolutely love Sheffield for. So the picture on the left is a sort of football mat, essential research. It's Prof. Kato and Prof. Hussain, and they are two amazing, amazing men. Prof. Hussain is a oncologist, and Prof. Kato is arguably one of the biggest urology profs in the world. They are hugely passionate about reducing inequalities in healthcare. We know that there are huge inequalities based on social deprivation. You are more likely to present with end-stage disease, metastatic disease, if you are in a more socially deprived area. And Yorkshire is one of them. And I've seen that a lot coming from London and the presentation rates of different urological cancers to Sheffield and South Yorkshire, where it's hugely different and you're in a different ball game as disease presents later. And they're doing great trials looking at ways to improve that and reduce the barrier you get between social deprivation and areas of north-south divide. And I'm really glad and grateful that they've given me the opportunity to do all the imaging for their trials, whether it's sorting out all the trial scans, reporting them all, or helping them with the grant applications for the imaging aspect of it. And we've had some cool visitors from Norway for some trial work that's been doing them there as well. So it's nice kind of worldwide interaction. So what exciting things are there in research? And I know research isn't there for everyone, but it is there, and it's there if you want it, and the opportunities are there, and I think are really exciting and emerging in Euro. The one that recently came out of Sheffield is that survival rates for patients with operable bladder cancer are significantly improved by giving immunotherapy before and after surgery. It used to be that muscle invasive bladder cancer in particular was a death sentence with a prognosis of 6 months to a year. These people are now living 5 years plus. This is a huge, huge game changer, especially in areas where people are presenting later and with highly aggressive disease. You've also got finesse. So obviously I'm the one in pink. That's looking at active surveillance of prostate MR with a finesse, with giving finasteride in 50% of the patients. So basically I just get to report even more prostate MRs looking at them. So that's exciting to think about non-inoperable management for prostate cancer in the first instance, and the opportunity to survey rather than putting people through an operation. Bladder path. This is what I absolutely love. I was sad this happened before I moved to Sheffield, but I'm so proud of the team for what they've done. We know muscle invasive bladder cancer has a really bad prognosis, and we're really bad at staging it. So you do a TURBT, there may not be muscle in, then you have to go to MDT, then you have to re-TURBT, and it adds and delays everything to get before you get a curative option for muscle invasive bladder cancer. But we also know that these patients metastasize within 2 months. So it's really crucial to get the diagnostic pathway accurate in order to put these patients on the right pathway. And so they looked at doing a randomized controlled trial of cystoscopy staging versus bladder MR for newly diagnosed bladder cancer. And what they found was having an MR-directed pathway led to substantive shortening of time to correct treatment for muscle-invasive bladder patients, with no detrimental effect on a time to treatment for non-muscle invasive bladder cancer. And so we have a role and responsibility to think about how we can accurately get up to date with doing high quality bladder MR, and how we can get it in the diagnostic pathway to improve outcomes. And this is something that we have the opportunity to do in our lifetime to make a huge difference to these outcomes and to this cohort of patients. So that's really, really exciting. And the one that I'm super, super excited about, and it got announced officially last week, despite me accidentally telling everyone secretly, is that we are part of our own prostate cancer screening trial in Yorkshire. So we're going to offer about 4,500 men in Yorkshire the opportunity to be screened. So it's part of a pilot study to then lead to hopefully to a full trial, which will then hopefully, with the other trials going on, give evidence to support potentially a national screening program for prostate cancer. I'm really excited we are going to do that. It's going to be a lot of prostate MRs, and I cannot wait. It's a chance finally to think about, can we get a national screening program? How do we combine PSA and MR in order to get an effective one for the men of the UK and the world? And I thought it's really good just to show you some fun and interesting cases about why I think Euro is brilliant. And the first one is a penile fracture. We love a penile fracture. So we do ultrasound plus or minus MR. Some places don't, but imaging, you can make a huge difference. So you can see here on the arrow, there's a defect in the tunica and a hematoma surrounding it. And why is it helpful? Well, actually, classically, they would do degloving. So you would do a circumcision, yank all the skin down. It's brutal. It takes long to recover. You are trained up in ultrasound, can show them exactly where the defect is. They can make a localized incision and help in recovery for the patient. That's a really great, satisfying way that you can help in those images. Everyone who knows me knows that there's one case that I'm famed for. Here's another penile ultrasound that I had once on a patient. And you can see corpus spongiosum here, and then two corpus cavernosum, and what looks like a kind of an echogenic bright thing in some kind of reactive material. And then when you look, it's moving. There is literally something moving in the penis. And what is this? So this is Diarrhea repens, aka a penile worm. You can get them also in the liver and the eye. There's a bit of GI for your ophthalmology, but it's not as cool. And then this is one that we've had recently, a prostate that looks massively abnormal, extending up to the umbilicus, that we've just biopsied, that we're wondering whether it's sarcoma. And here you go, random for me and rogue, but let us applaud the fact that I've not talked about a penis or a prostate. Here is a hypervascular lesion that we've had in the retroperitoneum. You can see it's causing hydronephrosis of the right kidney, and the hypervascularity is extending down the retroperitoneum and encasing the gonadal vessels and the ureters. We're not quite sure what it is at the moment. It is secreting some stuff with the endocrine, so it's either a very avid paraganglioma or an angiosarcoma. And what I love is I often found that as a trainee, you felt bad if you asked people for advice or wasn't sure what was going on. As a consultant, we are always emailing each other. What do you think of this? What do you think of that? The amount of times I email my GI, is this a poo or is this a rectal tumor? This case has got everyone interested with lots of different opinions. So we're all looking forward to the histology. Every day is a learning curve, and it's great that you can all learn together. So why is uroradiology so great? Why do I think you're in for a treat if you choose it as a subspecialty? Well, I think the best way is to look back and the people in my career who've shaped it. And I think this explains it why. So first off, I'll go shout out to Claire Allen, who's the best uroradiologist in the world, and Dan Hay. They trained me when I was at UCH. Everything I know is down to them. And I'm so grateful that they invested in me, and they still continue to invest and offer me friendship now. We still have a WhatsApp chat. We speak most weeks. And I'm really grateful that they took that time to really invest in me, and it just completely made me who I am now. So you will have people that you can look up to, and hopefully loads in Eurorad. So cling on to those mentors. It's nothing more satisfying than training up and inspiring the next generation. Sometimes you work with people that aren't so nice. Well, you can just learn from it and think, I won't want to be like that to other people. Cherish the people that invest and care about you, and it just makes you able to thrive, and that's what we want. Here's a urologist at Sheffield. That was us when we striked. And what I love is that they care so much about doing good care, and they took me in under their wing and they made me part of the team, even though I had no real link to Sheffield when I applied, and I didn't know anyone there. But you wouldn't know that now after working here. Shout out to Prof. Cato, my absolute hero. He is a genius of a person, but he's also the nicest, most humble man that you'll ever meet. He cares so much about reducing health inequalities and doing the best for patients, especially areas of social deprivation and places in Yorkshire where outcomes are worse. But he always does it in a really kind way. He's always been there for me. He's inspired me to do the best. And I'm really grateful that he lets me be part of his research. And we're essentially teammates in that. And honestly, it's just so great when you can work with people that bring out the best in you and give you opportunity to thrive. And here's a shout out to the rest of them. So you've got Prof. Cato, Prof. Hussain, you've got Steve Kennish, who essentially got me the job in Sheffield, and I'll speak quickly about BSUR at the end. He saved the job for me, even though I was just a trainee in a fourth year. And it's so good having someone that you can look up to, and it's essentially taking you under the wing and enabled you to thrive. And then Aidan is a urologist who's in our group chat, but he always complains if I don't shoot a shout out to him. So shout out to Aidan. And then finally, BSUR. So these are the rest of the girls on the committee. They all do gynae, so they will have a lot more to say about it than my solitary slide. Faye Cuthbert gave the talk at my first ever BSUR conference when I was a trainee at second year. And I remember being like, wow, she's amazing. I wish I could be like her. And now we're friends. And she messaged me to check that I'm doing okay. She gives me career advice, advice about colleagues, about work, about cases. And that's all to do with BSUR. BSUR is how I got my job. I went as a second year to Sheffield, met Steve for the first time, apparently asked for a job, which I don't remember doing, but it sounds like something I would do. I remember seeing a team that I had never seen before that was fun, that got along with each other, that wanted to do research in a really kind of collaborative approach. I knew because I wanted to do a subspecialty Euro to a higher standard that I wanted to do that. There was only limiting where I could work. There's only a couple of places, and Sheffield was one of them. So when they advertised a job in fourth year, I look back and I can't believe I did it. I sent my CV and was like, "Hey, Steve, remember me? I did loads of posters at prostates at your conference. I'm really interested in your job. Can we meet up?" And the rest they say is history. And I wouldn't have got that job without BSUR. And so BSUR, we are doing our conference this May in London, and we would absolutely love to have you there. There's a workshop on the 14th, and you can either do gynae and placental imaging, or you can do renal and bladder. Apparently, there's a really excellent bladder talk by a very talented individual. And then our conference is on 15th and 16th of May. I'm helping sort out the trainee scheme for part of that. So we have themed trainee topics set apart for you guys. It's the best way to get to know if urology is for you. I absolutely love meeting people. I would love to meet you there and say hi, share my experiences, have a think about what we can do to help you get you where you want. But that's where you meet uroradiologists, Uro and Gynae and Uro and IR from across the UK. You can truly see if that's a career for you. You can see what jobs are coming up. You can learn. I always found the talks out of all the conferences that I went to as a trainee, because I used to max out my study budget. BSR was the most accessible, and ultimately led to me making a bold move from London to Sheffield for my consultant job. But the rest, they say, is history. So please come. I'd love to see you. And thank you for listening. I hope it was helpful.
Thank you very much, Rachel. That was really exciting and fun talk on Uro radiology. If anyone has any questions for Dr. Sharon or Dr. Rachel, please post them in the chat. I've got a question for both of you. When I've previously been spoken to consultants about their specialties, one thing that they've mentioned is make sure that you're okay with the frustrating or challenging parts about the specialty. And I'd like to ask both of you what that is for your specialty.
Ladies first. I'll let you go first, Rachel.
Oh, thanks. I was going to say they've heard my voice. I think there's always frustrating aspects of any job. And when I get frustrated, and I got frustrated at work this morning, I often have to think about the motive of why I was getting frustrated. And generally, most people in radiology and most medics generally are nice people. So when you're getting frustrated, there's often an underlying reason. And the reason I got frustrated this morning was because I was nervous about not doing a good job on this talk. I'd booked extra patients on Flurry that were complicated that the A&P couldn't do, so I was having to rush and do that. I was then having to set up an on-call exam for the trainees in Sheffield. So I was doing 10 million things at once. And I just got frustrated. I get frustrated when I can't do a good job for patients, or when we're under-resourced, or we can't seem to get good access that we might have necessarily got in London. But I think ultimately, any frustrations that you have are often system built around an underfunded system. But actually, the majority of people in your team will share that frustration. And actually, you then keep going, because it's like if you're at a beach. I remember there's this analogy of this kid at a beach, and there's been like this, I don't know, tsunami, and there's like hundreds of starfish, and the kids are throwing the starfish like back in the beach one by one. And the dad is like, "Why are you doing that? You're wasting your time. There's so many starfish are dying." And the kid's like, "No, it matters to this one. It matters to that one." And so even though there are frustrations in the job, which I would say is probably due to underfunding, actually you do your best because it matters to that patient that you're doing the scan on, or you fitted onto the list, or you're like proving that they can have a TWOC, or you're fitting them in later to get their cancer staging for the operation. If that makes sense.
Thank you.
Yeah, I think if you've nailed it there, Rachel. That's the NHS itself is frustrating, isn't it? Because the systems don't always work, because the funding is poor, because services are not well reassessed and redeveloped from where they were 10 years ago, for example, and you can't change things to the way you want them to be for a modern day healthcare system. That's extremely frustrating. I think that crosses all specialties. You've sort of got to get over that and find a way, whether that's by making friends with your managers, using your clinicians to leverage the things that you need from their side as well, crossing directorates and things like that. But you learn that as you go along as a consultant. You know, influence is difficult, but getting things done is an art. I suppose in GI, the biggest and HPB, the biggest frustration I have is just having too much to do. You know, it's not uncommon that I'm in the middle of a session and I'll have 2 or 3 doctors outside my door waiting to ask to review some scans. You know, that's a really common one, and I know that's the same for everybody. And it's frustrating because you're trying to get on with the stuff that you're doing, but in a way also it's the biggest compliment that you can get, that they've come all the way down there to see you because they want your opinion. The truth is, you know, as much as we say, you know, clinicians sort of behave and say, you know, I just need a report on this, or just need that scan sorting. They don't mean that. They want a good report, and they want a good opinion, and they want help so that they can decide what they're going to do with these patients. That's where our role lies. You know, it's not in just churning out average reports. We always do our best, and you can only do that if you're interested in the specialty, I would say. So, yeah, I think that's a roundabout answer to the same question. But you know, I personally, apart from that, I don't have any time. Yes, there's not enough time in the day. But they're all generic frustrations. I have 0 frustrations with my specialty or what I do in terms of what it is, you know.
Thank you.
I was going to, oh, sorry. I was going to ask, the experience that trainees get varies so much around the country, dependent on, you know, geographic area, and we've spoken about the inequalities that exist within both the NHS and within different hospital settings. I mean, some trainees, for example, may not get much exposure to upper GI services. Others, for example, may struggle to get, you know, a full range of exposure to other forms of imaging. For those that are interested in both GI and uroradiology, what would you say are the best, you know, the best way of going about getting the broadest experience possible? Would it be, for example, fellowships or attendance at conferences? What would you say for trainees that want to get the most out of exploring these areas of radiology?
I'll let Sharan go because he'll go first. He did a fellowship.
Yeah, I'll go first. I think they all add something, you know. I think, you know, as you're going through radiology training, sort of what sort of standard you're at. Okay, I thought I was okay. I thought I was good at GI, and I thought I was a decent general radiologist, but I didn't see myself as super duper at gastrointestinal GI or HPB, and I wanted to be better. So for me, an intense fellowship sort of made sense. I uprooted and went abroad. I got married before I CCT'd, so my wife had to come with me, and we had our first baby out there, so our daughter's Canadian. And it was all a big experience, you know. Yes, massively disruptive, so you've got to be up for that. But you know, I think that fellowship has really shaped my motivation, my standard of working, and it made my first years as a consultant sort of very easy to sort of navigate in terms of, I found the clinical work easy. It was me looking around going, actually, we should be doing this, and me having an environment where my department lead was very much like, if you think we should do it, show us how and we'll do it. And it was, you know, that's how I ended up developing services. If you're not getting the experience that you think you want, that really just tells you you're not, in all honesty, you're not in the right place. You do have to look for where you can get that stuff. Conferences are great, but they're not particularly hands-on, and they give you a bit of education, but you don't take those away and go back to a place where you're not doing that stuff and get more experience. You know, there's lots of virtual online learning now as well. Buscar has 2 different virtual learning environments for ST1 to 3s in the academy, and ST4s up to senior consultants as well. And there's lots of archived videos to watch as well. But again, like I say, they're brilliant, but they're not going to sit there with you day to day and help you get better at something. So you've kind of got to decide what you need and where. And you know what I would say, and certainly my experience is, getting your CCT isn't you finished. I've been training since I was a consultant in 2013, and I'm still training now. I'm, everything I do is still learning, and there's always cases I still get wrong. Not often, but they do happen, and you learn from everything. If you're not getting the areas that you want, it just means you need to go and find it. And you might not get that in your training scheme. You might need to look for a place as a consultant where you can go and get that, and be prepared to learn on the job. But I think that's one of the really great things about radiology as a whole, our jobs, and it'd be nice if everything happened everywhere, but we're never going to get that. That's a long answer to a short question. Apologies.
Great, thank you.
I would just say join the subspecialty. So BSUR, the conference is really geared towards trainees, and you get to see people who work in different centres and exposes it to what you like. And then you've got the online resources. And then ultimately it's up to you and what you want. There's no right answer. A fellowship for one might be right, and a fellowship for someone else might not be. I didn't do a fellowship. I had a job lined up, and I so actually, if I was to go to a fellowship, where would top UCH in the place where prostate MR happened, and I couldn't find it. And for me, it was more important when I spoke to Steve and the team in Sheffield. Actually, I just needed to take that step out into being a consultant and learn on the job, and that was what worked for me. But everyone is different, so a fellowship for you might be really beneficial if you're not getting the what you think the right exposure is in your area, and that's where your college tutor and your TPD are there. And everyone, we love a challenge. Like, that's what they're there for. They're there to help you, like whether it's to get your exams or go, okay, you want the sub-spec, are we offering you here? No, do we need to think elsewhere? So actually go and use the systems that you've got. But the societies like BSU or BESCA will show you what happens elsewhere, and they'll show you the educational resources. But ultimately, the team and the TPD and your college tutors for your areas are there to help you to make sure that you're meeting and are able to access those, so that there's no difference based on where you're at. And they would be more than happy. I know I would, as college tutor. I would love it if a trainee came to me and said, this is what I want to do, and we can sit down. My trainee doesn't want to do Euro, but it's a great challenge actually going, right, what do you want to do? Where are your strengths? What are the options? And we have a responsibility to get you trained up and to get you to be the best consultants. And so that's one way to ensure it happens too.
That's great. Thank you so much. I don't think, unless I can't see any of the comments, I don't think there are any further questions in the chat. I don't know, Hanida, if you've got any others.
I think that's all.
Amazing. Perfect. So we look forward to seeing people for session 3. Details for that are on the RCR website. Thank you once again to Dr. Wadhwani and Dr. Hubbard. What fantastic talks. We really hope it's been engaging and really gets people thinking about using, well, not only these RCR resources, but also considering careers in GI and also uroradiology. Definitely have a look at the BUSCA and BSUR resources that have been mentioned, and look forward to seeing everyone in session 3.